Yeah, yes, ma'am.
ఈ మీటింగ్ కి they're putting up messages to me that they haven't received.
Ask them to check in spam box, madam. Mail box ఉంటుంది spam ది దాంట్లో.
ఏంటండి?
స్పామ్ లో చెక్ చేయమంటున్నారు.
స్పామ్ లో చెక్ చేయండి మేడం.
స్పామ్ లోనా? ఓకే, I'll put up a message.
ఆ రోజు నాకు తీరాలో కంప్యూటర్ నుంచి డిఫరెంట్ గా వచ్చింది అన్నారు కదా వాయిస్, ఇది బానే ఉందా?
ఇప్పుడు కూడా బ్రేక్ అవుతాను నవీనా.
ఇంకా నేను నా ఫోన్ నుంచి చేస్తాను మేడం. ఇంకా ఇది మరి ఎక్కడ ప్రాబ్లమో తెలియట్లేదు.
మీరు ఫోన్ నుంచి జాయిన్ అవ్వండి.
సరే మ్యామ్. ఓకే.
Shima, if they want to record on their computer also, they can record this, or it's not worth it. YouTube link you will send.
For that also I should have to ask to Ajay sir, madam. If Ajay sir said okay, then I can share the link.
Jyoti, you don't need to record the program. This will be available on YouTube. There, you don't need to record it on your computer because it will occupy a lot of hard disk space.
Takes more than 1 GB, madam.
That it'll slow down your computer like anything. It'll be there on YouTube. All the Meet is keeping that whole thing on the cloud for us now. Whoever wants, whenever they want, they can check it out. Yeah, 25.
Madam, many messages I'm getting that they have not received the link. I'm putting up reply to all of them, and in the group also I'm putting to check spam folder of mail. 10 మంది దాకా మెసేజ్ పెట్టారు, మాకేం రాలేదు ఇన్విటేషన్.
రాలేదని పెట్టారా?
ఇన్విటేషన్ జూమ్ ఇన్వైట్ రాలేదని పెట్టారు.
Good evening, ma'am.
Good evening.
Ma'am, this is Dr. Shweta. Ma'am, even I didn't get, but today when I registered back again, I got the email, ma'am. So I think if they can register now, they might get.
I know.
Okay, fine. I'll put up that message then.
Now if you give the link in Vox official and 1 and 2.
Madam, Padmaja madam, it's an individual link for each person. The link given to one person is not working for somebody else. Only
I remember that. So each one has to log in on their own because post test need to do.
Yeah, because they have to answer the post test, kada. So it's like only one link to one person.
One device allowed through one link. Second device is not being allowed.
Okay, adi kuda unda.
When it is live on YouTube, they can watch it on YouTube. They'll get the post test in the mail later.
No, madam, they'll not get if they watch through YouTube. They have to be present.
Okay.
That is for only students who were there in hybrid session. Here it is not done.
Okay.
I'm putting up message to re-register again.
The link, Navina, where did you find the link?
Ma'am, mail lo same Feb 21st na vachinade joint Zoom meeting RS. Ante Dheeraki they used to send a separate thing like you are the master trainer and all, but we didn't get that link today.
Madam.
Yes.
Madam. Madam,
Shriman.
they can't register now, madam, because the capacity is full actually. 100 capacity is full. I'm resending the confirmation mail. Ask them to check, madam.
Okay,
I'll send it
fine,
to
fine,
everyone.
fine. Yes.
Okay.
Selja, tell them to check the mail again.
Okay. Mail is being resent.
Because those original 100 people are there now. So,
Okay, fine.
ఒరిజినల్ 100 పీపుల్ కూడా రావాలి కదా మ్యామ్ యాక్చువల్ గా.
no, that is what the thing is. Some of their mails going to spam, some going to promotion, some go.
Okay.
Then sometimes
I'm sending that audio message. Sorry, I forgot to mute myself.
So sometimes what happens is control A, control delete wins. I'm sure my Dira certificate is like that, only gone.
No. Actually, me too. I got the RAC certificate for Dira. They said you have taken the same email. I have sent screenshot to Sailja ma'am. I've checked in everything, all motions and all. Usually I don't delete anything. So I have checked. No, I haven't received that mail.
నాకు కూడా డిలీట్ చేయాలని చేతిలో ఒప్పవు. సో అందుకు మా కూర్చోబెట్టి whatever you important which I have not seen in the last 6 months, you have the freedom to delete. And ఆ పిల్ల విరవి she said delete.
Yeah.
Array, we are on YouTube live, they're saying you shouldn't keep up with chat.
I think they'll edit, ma'am. They'll live streaming on the other.
Chalo, we have 34, 1/3. Quorum undi Selja.
Shailaja.
Papa, she must be from morning. She's in line juggling around.
Madam, ఒక్కటే 5 minutes wait చేద్దాం. Mails అన్ని రీచెక్ చేయమని మెసేజ్ పెట్టాను. పాపం many of them are trying to join.
Yes. That number is slowly increasing anamata.
Yeah.
Internet the bars ఉంటాయి కదా, speed you then you have one more coming atla 36 అదే.
సుశీల మేడం
చెప్పండి
మేడం. అమరావతిలో మెడికల్ స్కూల్ అంటే ఎక్కడ?
మెడికల్ స్కూలా?
డాక్టర్ లక్ష్మీ రాజ్యం చుండూరి అవర్ ఓల్డ్ విజయవాడ సొసైటీ మెంబర్ ఆ మెడికల్ స్కూల్ లో చేస్తారంట.
No. SRM ఈ రామచంద్ర యూనివర్సిటీ SRM యూనివర్సిటీ అన్నట్టున్నారు దాంట్లో.
SRM యూనివర్సిటీ అమరావతి.
అవును, ఇన్ దట్ మెడికల్ ఆఫీసర్ తను. మెడికల్ స్కూల్
కాదు,
మెడికల్ ఆఫీసర్.
ఇంజనీరింగ్ యూనివర్సిటీ మాది. స్మాల్ యూనివర్సిటీ మెడికల్ సెంటర్ లో నేను ఇప్పుడు వర్క్ చేస్తున్నాను.
ఓకే
మేడం ఉన్నారు.
గుడ్
గ్రేట్, చాలా బాగా మాట్లాడారు మేడం. ఇట్ వాస్ లవ్లీ.
చెన్నైలో మెడికల్ కాలేజ్ ఉంది
ఓకే.
ఆ యూనివర్సిటీ క్యాంపస్ అన్నమాట ఇక్కడ.
ఓకే.
సో ఇంజనీరింగ్ కాలేజ్ స్టూడెంట్స్ తీసుకున్నారు.
ఇంజనీరింగ్ అండ్ బిఎస్సి, బికామ్, బిబిఏ, ఎంబిఏ.
Okay, but
working there, Susila. Madam joined us in a Dira program for a school today.
యూనివర్సిటీ మెడికల్ ఆఫీసర్ నేను.
యూనివర్సిటీ మెడికల్ ఆఫీసర్. ఓకే.
చిన్న మెడికల్ సెంటర్ ఉంది, దాని మెడికల్ ఆఫీసర్.
ఓకే మేడం.
అమరావతిలో ఉండేది విఐటి SRM అంతే, ఇంకేం లేవు.
అంతే మేడం.
హైకోర్టు. మాకు రోడ్స్ లేవు, చుట్టూత చెట్లు.
Back to nature, madam. You're enjoying free breeze.
Yes, we are staying on the campus only.
మెసేజ్ పెట్టారు, why don't you start, it is 5:10.
Madam, I send the mail to all the participants who are registered for the program, madam. I send it to everyone.
Yes.
Only 100.
Okay. Selja will start off because those who came are waiting. People will join.
I think
And
శైలజ మ్యూట్ లో ఉన్నారు. శైలజ మ్యూట్ లో ఉన్నారు. యా
we can't hear you, Selja. Your computer audio is low.
శైలజ not audible.
Sridevi madam, we are just waiting for people to log in. Am I audible now, madam?
Yes.
Sridevi Vellanki madam 5:10 అయిపోయింది అని మెసేజ్ పెట్టారు.
That's busy.
ఇంకొక 6
Madam,
మెంబర్స్
many
ఇస్తే
people
హాఫ్
did not-
సెంచరీ చేస్తాం మ్యామ్.
Yeah, maybe 50 start
ఆ
చేద్దాం.
50 క్రాస్ అయిపోతే స్టార్ట్ చేసేద్దాం. They will keep joining.
Some of the slides, no, they repeat in different modules, Selja, like amendments
Okay.
and all that. So,
మ్యామ్ నేను ఇందాక మళ్ళీ కంప్యూటర్ నుంచి మళ్ళీ ఫోన్ లో లాగిన్ అయ్యి మళ్ళీ పీపీటీని ఇది చేసేటప్పుడు అప్పుడు దిస్ డాక్యుమెంట్ హ్యాస్ బీన్ మోడిఫైడ్ ఎ లాట్, మళ్ళీ రీలోడ్ చేయండి అని చెప్పొచ్చింది. పొద్దు నుంచి అదే
మీరు నవీనా గూగుల్ పేజ్ లో బుక్ మార్క్ చేస్తే మీకు ఫ్రెష్ ఓపెన్ అవుతుంది. ఎన్నిసార్లు మోడిఫై చేసినా ఫ్రెష్ దే ఓపెన్ అవుతుంది.
అదే ముందు ఒక మెసేజ్ వస్తుంది, పాపప్ మెసేజ్, దిస్ హాస్ బీన్ మోడిఫైడ్ ఫ్రమ్ వాట్ యు హావ్ సీన్ లాస్ట్ అని చెప్పి.
అదే ఫ్రెష్లీ మోడిఫైడ్ వస్తుంది చేస్తే.
Selja, we've reached 50.
Madam will start.
Yes.
Okay. Good evening and welcome to all Vijayawada Society members who have registered for this MTP Respectful Abortion Care Training session. We have 3 master trainers from WOGS today who will be elaborating on different aspects of the MTP Amendment Act, WHO toolkit and other things. We have Dr. Susila Pinnamaneni, Dr. Padmaja and Dr. Navina. We are starting with the first session. We are already delayed because of the late logins. Dr. Susila will be starting the first session.
I share my screen.
Yes, ma'am.
Is it?
We can see the screen, ma'am. Yes, ma'am.
So, good evening, all. Before I start the program, I would like to thank the organizers for giving me this opportunity. And also I welcome the delegates, the doctors to say, who are like logged in, and almost like 50 of you have logged in. So this is a joint venture of FOXI along with the WHO regarding the respectful abortion care. And we are going to talk for the next 2 hours regarding the amendments, regarding the guidelines of the methods of abortion, and then the counseling part of it, and also regarding the respect what we are supposed to give to the abortion seeker. So so most of our doubts which we have been like talking, like we are posting in our WhatsApp group, I think will be clarified after the session, by the session, we end this session. So before I start, just a small overview regarding the new MTP Act. So this act has been passed in the Lok Sabha around March, and then it was gazetted in September and October around that time, and it is almost like 4 months it has come out, and but we still have to know what all are the new laws and what are the changes that have been made in this old laws, and then we shall see in the next few slides. So unsafe abortions in India lead to the mortality, morbidity, and hamper the women and the girls' full participation. And 8% of the maternal deaths per year are due to the abortions, and they contribute to the third leading cause of maternal mortality. Nearly 2 out of 3 of the abortions are performed by the untrained personnel and also at the unsafe place. And nearly half of the pregnancies related deaths are in women and girls under 24 years of age. So when is the abortion considered to be safe? So if the abortion is done at the by the trained person and by appropriate method, it is considered to be safe. So both the criteria are to be met. Otherwise, it becomes an unsafe abortion if both the criteria are not met. And if one criteria is met, definitely it would be a less safe method. So at this point, we also should understand that it should be done at a proper place and also which is certified by the government. And also we need to understand that we can only do up till the gestational limit which has been passed by the law. So otherwise also it would become an unsafe abortion. So the medical termination of pregnancy amendment is considered as safe and comprehensive care, and it has been mandated by law. We all know that the 1971 MTP Act was launched mainly to make this abortion safe, but the new act makes it as a safe and comprehensive law. So what are the modifications that have been done in the new law? Is the modification, there are like 5 points we should understand. The first one is a modification in requirement of the provider. So in the previous act, it was one provider opinion for MTP till 12 weeks of gestation, and the requirement of opinion of 2 providers for between 12 to 20 weeks of gestation. So in the new act, it is the opinion of one registered medical practitioner for termination of pregnancy up to 20 weeks and requirement of opinion of 2 RMPs for termination of pregnancy between 20 to 24 weeks of gestation. Why this has been changed? This is basically to increase the number of facilities, especially in the public sector like PHCs, where the service can be provided till 20 weeks. That is, usually the PHCs have a single registered medical practitioner and they have to refer to the district hospitals or they have to refer to the medical college hospitals. But now, with the change in the act, the doctor at the PHC, who is a registered medical practitioner, can perform the MTP there and extend the services and make the services available. So the next modification and the second modification is regarding the vulnerable group of women. In the previous act, the MTP was only permissible up till 20 weeks of gestation. And now in the present new act, it has been enhanced to 20 to 24 weeks only in the special and vulnerable category of women. It is not like a blanket abortion to everybody. We should remember that it is only for the vulnerable category of women between 20 to 24 weeks, it is allowed. And further enhancement for the birth defects not compatible to life on the medical board consensus can be performed. And why this change has been made is to increase the access for the vulnerable women for the safe and legal abortion services. And the third point would be regarding the modification for birth defects and congenital anomalies. So even if we diagnose lethal abnormalities in the according to the previous act, we were not allowed to perform MTP after 20 weeks. But in the new act, there is no upper limit. And then at any gestational age, the MTP can be performed in case of substantial fetal abnormalities. And after the medical board opines, we can go ahead with the MTP. So why this change has been made is to increase the access to safe and legal abortion services who often seek service late beyond the legal limit for termination of pregnancies with substantial fetal anomalies diagnosed late, thus reducing the unsafe abortions and court cases. So there is no point in continuing with the pregnancy after we diagnose a lethal anomaly by ultrasound. And now we have good resolution ultrasound machines and also fetal medicine specialists who can diagnose the missed abnormalities and also evolving heart abnormalities. And all these pregnancies can be terminated, and the role of the court ends once a medical board is formed. And the other modification is regarding the marital status. So failure of contraception was applicable in the previous act only to the married woman and her husband, but now it has been extended to any woman, that is irrespective of the marital status. So this provides increased access to safe and legal abortion for any woman irrespective of the marriage age, especially in the change in the reproductive norms and also the socio-cultural profiles, and also upcoming change in the legal age of marriage. This is definitely an advancement to increase the access to the safe abortion. So the fifth point is regarding the insertion of the new clause for strengthening privacy. So in the previous act, the medical termination of pregnancy regulation 2003 mentioned that information should not be disclosed except under the authority of law. But in the new act, the name and other particulars of the woman whose pregnancy has been terminated shall not be revealed except to a person authorized by any law for the time being in force. That is, we cannot write the name or any detail of the woman anywhere, either in the OP card or in the IP card, and all the forms and the admission register are to be kept under lock and key, and it can be opened whenever an authorized person by law approaches and asks for the details. So till then, we are not supposed to reveal the identity of the person. So increase in privacy and confidentiality of the abortion seeker helps to safeguard their rights and the dignity of women and provide respectful, bias-free services, including the counseling and contraception. So it decreases the stigma of the abortion seekers, and hence a better availability for the increasing demand of abortions. And basically, the salient features of the MTP Amendment 2021 is it prioritizes the confidentiality and safety of the women, and also in regards with the contraception failure has been extended to the women irrespective of the marital status. So the rules under MTP Amendment 2021 defines special or the vulnerable category of women, and also it defines the norms for the registered medical practitioner, and also it defines the powers and the functions of the medical board. So who are the women who come under the vulnerable group? Are the survivors of the sexual assault, rape and incest, women with pregnancy in the humanitarian settings, disaster or emergency situations as declared by the government, change of the marital status during the ongoing pregnancy, that is a woman becomes a widow or a divorcee, women with physical disability as per the Disability Act, mentally ill women including the mental retardation, minors that is under 18 years of age, and the broadest of all these is covering the fetal malformations that has substantial risk of being incompatible with life, or if the child born would suffer from a physical or a mental abnormality to be seriously handicapped. So these 7 categories are called the vulnerable women, and we can offer MTP between 20 to 24 weeks. So we have to remember that is no blanket abortion for every woman between 20 to 24 weeks, and only we can perform abortion for these women from 20 to 24 weeks. So regarding the norms for the RMP is defined as an MBBS doctor with the following criteria. That is a medical practitioner who has assisted 25 cases of MTP and who have done 5 cases independently in a hospital, or 6 months house agency in Department of Obstetrics and Gynecology, and who holds a postgraduate degree or diploma in the Obstetrics and Gynecology department, or has an experience for at least 1 year in the Department of Obstetrics and Gynecology. So these are the defined criteria of RMP as per the previous act. So under the amended rule 2021, an additional category of provider has been added for termination up to 9 weeks with medical methods. So they are RMPs with experience in the practice of obstetric and gynecology at any hospital for 3 months, or training with performance of 10 cases of MTP by medical method of abortion under the supervision of an RMP in the hospital established or maintained or a training institute approved for this purpose by the government. So this is regarding the medical method of abortion. And one RMP opinion is required up to 20 weeks, 2 RMP opinion from 20 to 24 weeks, and beyond 24 weeks, it is the opinion of the medical board. So till 9 weeks, it is experience at any, till 9 weeks, an RMP who can perform the abortion is has to have an experience at any hospital for 3 months in the practice of obstetrics and gynecology, and who have done independently 10 cases of MTP by medical method of abortion under the supervision of an RMP in a hospital established or maintained, or a training institute approved for this purpose of government, or a practitioner who has assisted an RMP in 25 cases, done individually 5 cases, or a postgraduate degree or diploma holder in OBG, or a practitioner who completed 6 months of house agency in obstetrics and gynecology, or who have practiced 1 year in the Department of Obstetrics and Gynecology. So these are the criteria for the RMPs who can do abortion up till 9 weeks. So till 12 weeks, again, it is a practitioner who has assisted an RMP in the performance of 25 cases of MTP, and 5 independently they must have done, and postgraduate diploma or degree holders in Department of Obstetrics and Gynecology, 6 months of house agency in OBG, or 1 year of minimum 1 year of practice in OBG department. So this is for 12 weeks, and beyond 12 to 20 weeks, a postgraduate degree or diploma holder in OBG, or a practitioner who has completed 6 months of house agency in OBG department, or a practitioner who has worked in Department of OBG for at least 1 year. So in these cases, it is like 12 to 20 weeks, and the same holds good between 20 to 24 weeks, but opinion of 2 RMPs is a must. And beyond 24 weeks, with the consensus of the medical board, a postgraduate degree or diploma holder in OBG can perform the MTP, and or a practitioner who has worked in Department of OBG for 1 year can perform the MTP. So it is all with the permission of the medical board, and the medical board advises all the precautions, and also advises regarding the appropriate counseling at an approved place. So a gynecologist, a pediatrician, a radiologist, or a sonologist can constitute the medical board. And what are the powers of the medical board? So a medical board can allow or deny the termination of pregnancy beyond 24 weeks of gestation, and they can also co-opt other specialists in the board for their suggestions or their due advices, and they can also ask for the additional investigations if required for deciding for the termination of pregnancy. So the medical board considers the procedure to be safe or not depending upon the gestational age of the women. So we all know that the second trimester abortions are risky, so they ensure that the procedure goes smooth and safe. And also they consider whether the fetal malformation is lethal, that is, it is incompatible with life, or they would have, or the fetus would have, the baby would have a physical or mental abnormality if born, and would have serious handicap problems. So the board considers all these, and then it gives an opinion whether it refuses or it allows the termination of pregnancy. So FOXI, with ministry guidance and WHO support as a part of respectful abortion care, can operate and host a medical board information on the website, and this is going to take place within few months from now. And the medical board examines the woman and also her reports, and it should provide its opinion on the Form D with regard to the termination of pregnancy or rejection of the request for the termination within 3 days of receiving the request from the abortion seekers. And the board also ensures that the termination of pregnancy goes with all the safety precautions, and the appropriate counseling is done. So this is taken care by the board, that the termination is completed within 5 days of the receipt of the request of the medical termination of pregnancy. So FOXI has an important role to play in ensuring the functional medical boards in every state as it is stated in MTP Amendment 2021. So India is a progressive country and abortion has been made legal, and let us make it safe and respectful, and let us decrease the stigma among the women who come for the abortion, and also talk to them about the contraception and also the reproductive health. So who all have joined today, they are supposed to do the post test and also give their valuable feedback so that you'll be awarded with the certificate by the FOXI and the WHO. So with this, I end the first session. And Shailaja? Can we go ahead with the second session, or?
There is one question, Susila. In the chat box.
Previously, when we were having permission up to 12 weeks on the same permission, can we do up to 20 weeks now, or should we apply again for the permission for the 20 weeks? This is regarding the registration of the center for the approval of the center. This, I think this does not come under the purview of this talk. I think I'll just find out and then let you know. So
we don't really have to reapply for all the MTP permissions. No, we are all those who were previously given by the DMHO permission, it still holds good.
I think Padmaja, it was like 12 weeks opinion of one, and then after that it is 2.
Yeah,
maybe.
But the center does not have to be reapplied. That now we will do up to 20 weeks.
Yeah. And, regarding where is the medical board? The medical boards are yet to be formed. The medical boards are under the state purview, and the FOXI is really trying to talk to all the state personnel and the health secretaries to form the medical boards. And already the medical board has been formed in RIMS Ongole and also GGH Guntur. So once our a team in GGH receives, maybe we'll be having a board in Vijayawada. So shall I start my second presentation?
Yes, madam. We'll go ahead with the second session.
So the second module is regarding the safe abortions and updates in the technology. So the overview is regarding the existing guidelines, pre-abortion assessment, medical methods, and the surgical methods of abortion. So WHO has brought about the guidelines on safe abortions, and many guidelines have been released like clinical practice handbooks, technical and policy guidance, medical management of abortions and safe abortion care, and post-abortion contraception. And in the last 1 decade, many of the guidelines have been released, and pertaining to our country, adaptation of WHO safe abortion guidelines in India has been released, and landscape assessment of availability and quality of medical abortion commodities in India. All these are available on the WHO website, and maybe we can go through whenever needed. So to say, definitely the MTP Act is a historic change, and it is a comprehensive care, and that has been mandated by the law. The law has been changed on 25th March 2021, and the rules have been changed on 24 and gazetted in October. So when we come to the management of abortion, there are 3 key areas. One is the pre-abortion care, the next is the abortion care methods, and the third is the aftercare follow-up, which includes the post-abortion contraception and the counseling. If a woman chooses to have an abortion, she should be allowed to choose from among the available methods that are appropriate to her based on the duration of her pregnancy and her medical condition. So the decision making has to be offered to the women, and she should be part of the decision making. And pre-abortion assessment and counseling includes detailed history taking, general physical and pelvic examination, And if needed, we can go for the laboratory tests and other investigations. And decision-making information on abortion procedures and counseling has to be given and talked to the woman. So we all know that the gestational age is determined by the last menstrual period and by physical examination. It is a pelvic organ up till 12 weeks and becomes midway between the symphysis pubis and umbilicus is 16 weeks, and 20 weeks reaches the umbilicus. And the fundal height in centimeters measured from the symphysis pubis approximates the weeks in gestation. And the limitations to dating by uterine size on physical examination are like uterine malformations, fibroids, multiple gestation, marked uterine retroversion, obesity, and molar pregnancy. And the uterine size does not match in or is smaller when compared to the size expected in women who is not pregnant, and the menstrual history is inaccurate, or in cases of ectopic pregnancy. The size of the uterus is larger than expected in case of multiple gestation, uterine fibroids, and molar pregnancy. And this slide mainly tells us that ultrasound is not always necessary, but we can just go by the LMP and physical examination unless otherwise required or we have a doubt. So the routine lab investigations are not a prerequisite, but we can go for the test depending upon the individual risk factors on the physical findings. And if we have a doubt that pregnancy is not confirmed, we can go for a pregnancy test. In case of anemia, maybe we can ask for the hemoglobin, and HIV testing counseling can be done. And STI screenings, that is sexually transmittable diseases screen, can be done when we perform a pelvic examination, and other laboratory tests can be asked in case there is an indication in the medical history regarding the kidney and liver, like they have a problem with the renal or the liver function. But one important thing what we have to understand is the rhesus testing, where the Rh immunoglobulin is available for Rh negative women. This is because if we don't give a anti-D to the mother, the reproductive outcome in the next pregnancy would be a problem. So maybe we need to ask for the blood grouping and typing. And ultrasound is not always necessary unless we suspect an ectopic pregnancy or a miscarriage. So ask the patient regarding the reason for terminating, and always it is a gray zone, that is she needs an emotional support, and then we have to talk to her and then help her for choosing the method of the abortion, and then inform her that the early abortion is safe and the importance of a trained provider for performing the procedure for their safety, and also discuss regarding the available methods of abortion and what are the risks and warning signs have to be explained, because they have to report in case they have a problem. And we need to discuss about the contraception. Without the contraception, the patient can become pregnant as soon as 14 days after the abortion. And talk to them regarding the resumption of the normal activities, including the sexual intercourse and the follow-up care. All this we need to document, and we have to take an informed written consent, and also we have to write on the file regarding the post-abortal contraception, whether we have discussed whether she has chosen any one of them. So if she's not willing for a contraceptive method or following a contraceptive method, we cannot deny the abortion services. But again, we can call her and then talk to her regarding the contraception and her reproductive health. According to Government of India recommendations, medical method of abortion is only permitted till 9 weeks. So it is a combined regime, that is mifepristone and misoprostol. Up to 49 days, mifepristone is given on the day 1, 200 milligrams orally, and then misoprostol is administered on day 3, 800 micrograms, either sublingual, buccal, vaginal, or oral. The same holds good for 7 to 9 weeks, but the only difference is misoprostol cannot be administered orally. It is either sublingually, buccally, or vaginally in the same dose. So in the global recommendations are less than 12 weeks, combined regime can like mifepristone or misoprostol, or a misoprostol only regime can be followed. And surgical method which is recommended is a vacuum aspiration. And the same medical methods hold good if it is like more than beyond 12 weeks. But The surgical method of preference is dilatation and evacuation and should not be followed by a sharp curettage. When it comes to the surgical method, it can be manual vacuum aspiration or an electrical vacuum aspiration. Mifepristone is an antiprogesterone. It inhibits the action of the progesterone. It causes a decidual necrosis, separation of the placenta. It sensitizes the uterus when misoprostol is administered. And the misoprostol causes softening, priming of the cervix, uterine contractions, and expulsion of the product of conception. And the process is hastened by the misoprostol. So advantages of the misoprostol: it is less expensive, heat stable, easily available. And we need to give the anti-D injection 50 micrograms if the woman is RH negative. If 50 micrograms is not available, full dose of 300 micrograms can be offered to her. Again, at the 7 weeks, it is like, according to our Government of India, it is 800, but we can as well give 400 micrograms, sublingually, buccal, vaginal, or oral. And 7 to 9 weeks, it is 800 micrograms sublingual, buccal, vaginal, no oral route. So in addition, we may give analgesics like ibuprofen in case of pain. In case of side effects like vomiting, antiemetics can be prescribed, and talk to her regarding the contraception. On day 15, that is the follow-up day, confirm the completion of the procedure, offer her contraception if she has not decided before. So we need to offer her contraception and then discuss with them. So these are the routes of administration of the misoprostol. It can be oral, buccal, sublingual, or vaginal. Oral and buccal are the have the fastest onset of action, and the peak plasma concentrations are reached about 40 to 50 minutes after the insertion, and hence the side effects like fever, chills, diarrhea, vomiting are more compared to the buccal and vaginal route. The side effects are quite less with the vaginal route. So in the vagina, the pills are placed in the vaginal fornices in the deepest portion, and the woman is instructed to lie down for 30 minutes. So it is like a inverted V, that is, peak is reached for, somebody is manipulating. Sorry. So we have to remember that the oral and buccal, the peak is reached, that is an inverted V. But in a buccal and vaginal, it is an inverted C. There is a sustained action. So the side effects are less, and we have a better and sustained action. So in case of the buccal, the pills are placed between the buccal mucosa and the gums, and the patient can swallow after 30 minutes. In case of sublingual administration, the 4 tab pills are put under the tongue, and the women can swallow after half an hour. So the WHO drug regime is 200 milligrams of misoprostol, mifepristone, 200 milligrams of mifepristone orally. Followed by that, on day 3, it is 800 micrograms of misoprostol, buccal, vaginal, or sublingual, and misoprostol only regime is 800 micrograms, either buccal, vaginal, or sublingual. So the vaginal bleeding is expected for 2 weeks, but sometimes it can be for up to 45 days. So if it is minimal, without any infection, that is without any foul smelling discharge, without any cramping pain, we need not ask for an ultrasound, and we can just follow up the women. So services should be available at the primary center regarding the medical methods of abortion. That is, it should be available at the primary care level. That is, even the women can give in the clinics, but they should have a referral system whenever a problem arises or a complication arises. They need to send to a higher level. And counseling and testing for sexually transmitted diseases can be done along with the when we are advising them the medical methods of abortion. We can also support with them for the abuse support services, psychological social services, and other specialist health and medical services can be given to them. Iron tablets can be given in case of anemia, and pain medication in case they complain of pain, and always provide emotional support to the patient, to the women. So follow-up is like, there is no routine follow-up. It is not necessary. if it is a combined regime, but a 7 to 14-day follow-up may be required to talk to them regarding the contraception, reproductive health, emotional support, and address their concerns. And routine follow-up is must and should in case of misoprostol only regime, because the success rate is comparatively less with this protocol. In the follow-up care, assess the woman's recovery, ask for the signs and symptoms of ongoing pregnancy, review her medical records and referral documents, ask about the symptoms, what she has experienced during the procedure, and perform a focused physical examination for any of the complaints, and assess the women's fertility goals, need for contraception, and provide them if they are choosing for. So in summary, day 1 visit, physical and pelvic examination is done, confirm their eligibility, advise them to take mifepristone 200 milligrams orally, offer her anti-D 50 micrograms if the woman is RH negative blood group, and ask her to tell the woman that they need to return on day 3 for misoprostol administration, give them the contact, address, phone number, and then where they have to come to the emergency, when they have to come to the emergency, and record her experience of any side effects on the MMA card, that is medical method abortion card. There is a specific card on the website of WHO. We can just download and give it to her. And 3% of the women, they expel the products of conception with mifepristone alone. And even though it is expelled, we need to complete the protocol by giving the misoprostol schedule. And on day 3, give the misoprostol 400 micrograms sublingual, buccal, vaginal, or oral. Observe them for 4 hours. If they have pain, ibuprofen 400 milligrams can be given for pain management, and contraception can be discussed again. And if the options like condoms, hormonal methods, that is COCs and injectables, can be started during the day 3. And tell the woman that the mean period of bleeding would be 8 to 13 days. And possible side effects would be nausea, vomiting, diarrhea, headache, fever, dizziness. And they need to report in case of excessive bleeding, pain, abdomen, or in case of fever or foul smelling discharge. And report if there is no bleeding in 24 hours after misoprostol. And we need to give them the additional dose of misoprostol again. 75% of the women abort within 4 to 6 hours after the misoprostol administration. And on the 3rd visit or the follow-up visit on day 15, pelvic examination can be done to ensure the completion of the process, and contraception has to be again reiterated. Hormonal methods can be started, and we can advise them to follow the barrier method. And if the process is complete, we can go for the insertion of IUCD, and we can ask the women to come back after the menstrual cycle for the permanent sterilization. So we need to tell the woman about the immediate return of fertility within 14 days, and they need to report back if there are no periods within 6 weeks. And we need to again reconfirm that process of abortion is complete or incomplete, or there is an ongoing pregnancy, and maybe we can opt for the surgical method again. And ultrasound is done only to confirm the completion of the process. Regarding the side effects and complications, when the patient complains of pain, we should be non-judgmental, we should be respectful to them. And then verbal support has to be given, adequate counseling regarding the pain should be informed to them. And we also have to support the person who has come along with her. And ibuprofen 400 milligrams can be given to her in case of persistent pain. We need to rule out ectopic pregnancy or an incomplete abortion or an infection. So nausea, vomiting, diarrhea are self-limiting. We need to reassure her. In case of infection, a physical and a pelvic examination has to be done, and we need to start her on the antibiotics. In case of failure of medical method of abortion, we can offer her vacuum aspiration, and as well we can repeat the same dose of combined regimen of mifepristone and misoprostol. And in case of the incomplete medical method, incomplete results of medical method of abortion, we can repeat the dose of misoprostol or offer her a surgical method of evacuation. And we can go for a medical, we can just go for a pelvic examination, and the uterus size is, if it is normal, it indicates that abortion is complete. But if the patient comes with heavy bleeding, that is bleeding more than her menstrual cycle or soaking 2 pads in an hour for 2 consecutive hours, then she has to report to the emergency, and we need to check the vitals of the patient, and pervaginal examination has to be done. And if any products are there in this felt in the cervical canal, a digital evacuation can be done, and we can just observe her. If the patient is stable, we can monitor her for the next 1 or 2 hours, and then can discharge if she meets the criteria of the discharge. And if the bleeding continues and the patient becomes unstable, we need to go for an ultrasound examination. And if there is a continuation of pregnancy, vacuum aspiration is best. Or if only minimal bits are there, we can wait and watch. And if if the woman is stable, we can just repeat a single dose of misoprostol of 600 micrograms orally or 400 sublingually. And if the woman again is bleeding heavily, we need to go for a vacuum aspiration. So if the woman is stable, we can as well watch, but if the woman is unstable, better is to go for a vacuum aspiration. So medical method of abortion, it does come under purview of MTP Act, and then it is similar to the vacuum aspiration procedure. So documentation has to be similar to that. And it is mandatory to fill the consent form, that is the Form C, Form 1, that is RMP opinion, and Form 2, that is a monthly reporting form, which we send to the district authorities, or DMHO has to be filled and sent every month. And Form 3, that is the register which we maintain in our hospital, has to be properly maintained. And the consent form, the RMP form, and the admission register have to be kept on lock and key. And unless an authorized person is sent to check, we need not open it at all. So the surgical methods abortion are the 2 types. One is a manual vacuum aspiration, other is the electrical vacuum aspiration. And vacuum aspiration is recommended technique of surgical abortion for pregnancies up to 12 weeks of gestation, and the manual vacuum aspiration is the safest method according to the WHO and hence recommended by WHO. And the procedure should not be routinely completed by a sharp curettage. So this is a handheld aspirator, and it works on a principle of negative pressure or creating a vacuum. The aspirator is attached to the cannula of 4 to 12 mm size in diameter, and it corresponds with the weeks of the gestation. That is, 8 mm cannula can be used for 8 weeks, and 10 mm cannula can be used for 10 weeks of gestation. So this is the electrical vacuum aspiration pump or the machine, and we generally use it even in our OTs during the cesarean sections and also the vacuum deliveries. So it creates vacuum by electrical method. That is, negative pressure is created with the help of the electricity, and we can accommodate the cannula of manual vacuum aspiration with the correct size tubing. And regarding the cervical priming, it may be considered for women with pregnancy of any gestational age to prepare the cervix and to make the cervix soft and easily dilatable. And the recommended methods of cervical preparation before surgical abortion in the first trimester would be the oral mifepristone 200 milligrams 24 to 48 hours in advance, or misoprostol 400 micrograms sublingually 2 to 3 hours prior to the procedure, or misoprostol 400 micrograms vaginally 3 hours prior to the procedure, or insertion of the laminaria tents intracervically 6 to 24 hours prior to the procedure. So this is mainly advocated in case of the scarred uterus to prevent perforation and also to prevent the rupture of the uterus. So the pain management can be non-pharmacological or pharmacological using medication. It is an important component of quality abortion care. It reduces the pain and anxiety and makes the woman comfortable. So the non-pharmacological pain management includes psychological support and We have to explain the woman in advance what the next step is going to be, so that she would anticipate and help us in doing the procedure, and also performing the procedure very gently and smoothly, and encouraging the woman to relax and breathe deeply. So the pharmacological pain management includes the anxiolytics like diazepam, and cervical dilatation, that is the paracervical block with 10 ml 1% lignocaine, or analgesics like ibuprofen can be given 400 to 800 milligrams 1 hour prior to the procedure. And in case of uterine cramping, ibuprofen 400 to 800 milligrams can be given 1 hour prior to the procedure. We should be careful regarding the gastritis because of the NSAIDs. Steps of the manual vacuum aspiration. We have to prepare the instrument, close the valves, create a vacuum by pulling the plunger backwards, and ensure pain management, that is medication has to be given, maybe a paracervical block can be given later, that is ask the woman to empty the bladder, and perform like we have to clean the cervix with antiseptic solution. Paracervical block can be given. Dilatation of the cervix has to be done if required, and we insert the cannula, and the cannula should be like 1 to 2 centimeters away from the fundus to prevent perforation, and a quarter round of rotation, that is from 10 to 2 o'clock position with smooth gentle motion has to be done, and the vacuum button has to be released so that the products of conception are aspirated. So the signs that the uterus is empty and the procedure is complete is with the red and the pink foam without any tissue passing into the cannula, gritty sensation over the surface of the uterus, and cervix gripping the cannula and the uterus contracting around the cannula. All these indicate that the procedure is complete. So we need to inspect the tissues, and we also need to like if the patient is willing, we can go ahead with the sterilization procedure, or we can insert an IUCD. The instruments have to be disinfected in 0.5% chlorine solution. It as well removes the tissues and the body fluids. So in the post-procedure care, monitor her for any complications and provide management as needed in regards to the complications. And she may leave the hospital if she is stable and all meets the criteria of the discharge. And ensure that the woman has all the necessary information and medication when she is leaving the hospital, and document everything on the client's record card as well as in our file. So aftercare is the management of the abortion complications. That is, in case of any incomplete abortion, infection, bleeding, ongoing pregnancy, we need to treat her. And again, we need to talk her regarding the contraception and counsel her. And also we need to talk to her about the sexual and reproductive health. And follow-up is like really there is no like a routine follow-up is required except for the meso alone regimen, which is a new recommendation by the WHO. So in summary, India has made historic progress in improving access to the safe abortion. Not much change has been there in technology updates in the last decades regarding the methods of the abortion. As providers, it is up to us to ensure safety, quality, especially in context to the amended law. Along with safety, we all need to focus on the respectful abortion services, and every client, either a private or a public client, we take the opportunity to educate them and equip them with the proper information regarding the contraception and counseling. So thank you. Let us make abortion safe and respectful, as the law has been passed and the abortion is legal. And I request you all to fill the post-test form after the completion of the next 2 sessions, and also give your valuable feedback. Thank you all, the patient listening. So any questions?
Thank you, Dr. Susila, for your elaborate discussion about the new amendment and the safe procedures for MTP. Now moving on, we have Dr. Padmaja to talk about MTP Saver Tool Kit. She'll be discussing about toolkit for the MTP, and I request Dr. Padmaja to take over.
Thank you, Uma.
Any questions? Any questions? Please post on the chat box, which we can, always bring up for discussion at the end.
I thank all the Voxians who logged on today and are listening to this extensive program. I'm talking about SAVER, which means Safe Abortion Values, Evidence, Rights and Respects. Basically, the aim is to, what do we mean, to basically define respectable abortion care, how these services are affected by norms and stigmas, and what are the resources we have to provide respectful abortion care. The momentum has already been created regarding abortion. The whole country knows it, women know it. There has been extensive debate over so many years that has resulted in the law being changed. Foxy is the largest provider base. And now with COVID, all of us are familiar with online training programs. We don't have to leave our place of work to do that. And basically, we want, Foxy wants very much increased uptake of early medical methods of abortion because it is safe. And there is absolutely no way we will get embroiled in the PCP and DTA telling that they determined the sex, they aborted, because at 6 weeks, 8 weeks, it is too early to find out the sex. And Dr. Susila has already highlighted about all the technical details. I'm sure all of you who are practicing PGs would have just read it. The practitioners already know all that. So what we are trying to do is put emphasis on patient safety, respect, and say that we care. So respect and quality matter more than anything else. So in respectful abortion care, we want to make sure that this care maintains the safety, dignity, confidentiality of women, ensuring freedom from harm and mistreatment, enabling them informed choice and continuous support during and after all types of abortion. So that is the sum total of what we mean by respectful abortion care. So irrespective of the race, ethnicity, gender of the provider, the socioeconomic status, reproductive histories, we should treat women with dignity and empathy and compassion. I mean, sometimes in our heart of heart, we might think, she's had an abortion, she's not following any contraception, she keeps coming back. Does she not know that another pregnancy will happen and it comes back again? But we have to understand that we cannot, we are not in their shoes. We don't know the circumstances in which they are there. So whatever it is our duty to listen, support, and keep communication channels open. So what are norms and stigma? So anything that I don't think any of us does this, but we would have heard that in the government hospital, there have been incidences of physical abuse, intimidating, verbal abuse by screaming and shouting at them. Some of the unfortunate women have been sexually abused by the providers. And sometimes even when we don't provide professional standard of care, it is still considered disrespect. When we're not able to communicate with our women, and when we have our health systems and conditions don't meet the criteria that is necessary for good health and the constraints of these health systems, all these fall under different categories of disrespect. The right of every woman is freedom from harm and ill treatment. She has a right to information. She is protected under the MTP. Having a termination of pregnancy is her choice and her right, and it is our responsibility to do it safely and with dignity. All of us should remember that less than 18 years comes under POCSO Act. Informed consent, she can always refuse, and we need to respect her choices and preferences, giving her the dignity and quality of care. So we need to make sure that timely health care to the highest level of health is the women's right, and they have an autonomy, self-determination, and they have freedom and coercion. So the domains of respectful abortion care, there are 12, and it is essentially reiterating what was the purpose and the aim of providing respectful abortion care, like being free from harm and mistreatment. And as Dr. Susila said, maintaining the privacy and confidentiality, preserving her dignity, respecting their choices, having effective communication, which is a soft skill that we need to upgrade ourselves. Make sure that we provide enough information so that they give us an informed consent, ensuring continued access, enhancing the quality of the physical environment and resources, equitable abortion services. And we are all competent. We should be motivated providers and emphasize more on continuity on care, talk more counseling, and contraceptive advice is what, and the community services we need to do. So we need to strengthen the implementation of the MTP Act, and it has become more simple and making it accessible to more people in the changes that have been made, so that up to 20 weeks, 1 RMP is enough, 20 to 24 weeks, 2 RMPs are necessary. If we find a reason for termination, even beyond 24 weeks, the medical board is there. And, when only 1 RMP is looking after them up to 20 weeks, it makes it us more responsible to provide counseling, contraception, referral, and compassionate care. And it is the onus is on us that there should not be any sex selective abortion. So when we look at, these are regarding the providers. Expanded eligibility, Susila has already touched on that. If people come late, special categories in young children who are abused or a victim of a rape, even up to 20 to 24 weeks, we can do it. All women can use our services up to 20 weeks. In birth defects, there is no gestational age limit and a board is needed. We are prioritizing confidentiality. So name and the particulars of any women seeking needs to be confidential. And failure of contraception has been extended to all women and not just married women. As we keep telling again and again, respect, quality, and dignity in all types of abortion services. I wonder whether this video will play. If not, I will come back to this. So this is a small video of 8 minutes in which they talk about as the fetus is not yet a child. Terminating pregnancy is commonly used. However, some people prefer to avoid this as terminate may have negative connotations for some people. For example, terminating cesarean. In some contexts, the
Padmaja madam, volume is very low, madam. Can you increase the volume?
Okay. Just a moment. This is the maximum. Abortion.
Madam, we can see only the video, madam. We can't hear anything. Your voice is not audible, ma'am. You are muted. Madam, unmute yourself. While sharing the video, the left side will have 2 seconds, madam. You have to click on the 2 seconds.
Is this okay?
No, madam. We can hear. We can't hear anything. This video is playing.
Okay, I will stop this.
And
Let us
start sharing again.
Stop share. One moment.
No, madam. While sharing the video before, you just click on, you'll have 2 check-in box in the left side, madam. You have to select those things. Audio, share with audio.
Share sound. Okay.
Yes, ma'am. The other one.
Now I'll try.
Yes, ma'am. Now you share the screen.
Many to be
Yes, ma'am. We can hear now.
due to conflations with other laws. Make sure that you share accurate information about the legal situation and make the circumstances under which abortions are legal clear. See the WHO Global Abortion Policies database for information on the legal status of abortion across the world. Let us look at some stigmatizing words and how to avoid them. Abortionist is a term used by those opposed to abortion. Healthcare provider is usually a more accurate term to use than abortion provider, as most of those providing abortion care also provide other health services. In India, they are also called RMPs or Registered Medical Practitioners. The preferred terms are medically accurate as the embryo or fetus is not a baby. When referring to the tissue examined following a surgical abortion, an appropriate term is products of conception. However, this term is only useful for materials focused on medical details of abortion, as it is not commonly used or understood outside of medical or scientific contexts. Conscientious or moral objector implies that those who do provide abortions are not conscientious individuals, which is incorrect. Refusal to services must be well founded. For example, sex selective abortion in India is illegal. This tends to suggest an act of wrongdoing, placing unwarranted blame on the woman and frames parenthood as punishment. The right to abortion should never be linked to how or why a woman becomes pregnant. Abortion is a woman's right and choice. Consider the classification of pregnancies into the categories unintended, unplanned, unwanted, or mistimed. The classification relies on a framework that assumes that pregnancy is, should be, or even can be a conscious decision. The complexity and possible ambivalence of pregnancy intention, as well as the dynamic nature of childbearing decisions before, during, and even after pregnancy, are not accommodated in these classifications. The suffix side denotes killing, which is not appropriate when describing abortion. When referring to sex selective abortion, it is more accurate to describe the practice in terms of choosing to end the pregnancy based on the predicted sex of the fetus. Make it clear that abortion is about making an informed decision and avoid the implication that ending a pregnancy is done without careful thought or consideration. The term keep implies a positive outcome which may not accurately reflect the situation. In addition, it is medically inaccurate to describe the pregnancy as a baby or child. It is more accurate to describe the situation as a pregnant woman choosing to continue with the pregnancy. Late term could refer to any time in the second or third trimester. Instead, if necessary, use terms that indicate the specific trimester or gestation. Use of late may also imply that a woman is late and thus irresponsible in seeking an abortion. For example, there is no gestation limit for birth defects and associated abortions in India as per the recent MTP amendment of 2021. Use of mother, father, parent during a pregnancy is value laden and assigns roles that the man or woman may not accept. It also implies that the fetus is a child, which is not accurate. Also, under the MTP Amendment 2021, in India, any woman and her partner, married or unmarried, can seek abortion. Abortion is not contraception. Contraception is to prevent a pregnancy, whereas abortion is to terminate a pregnancy. People often seek abortion due to the occurrence of an unintended pregnancy or for health reasons, and there will always be a need for safe and legal abortion. All reproductive choices and care should be available and supported. People should be supported to prevent unintended pregnancies with access to contraception and accurate information. Pro life implies that those who support legal abortion access are anti life, which is inaccurate. Instead, use alternative terms to make it clear that you are referring to individuals opposed to anyone having an abortion. Where possible, our language should reflect the fact that we are service providers with a focus on providing rights based quality healthcare and support. In order to dispel myths about organizations that provide abortion care, it might be useful to avoid business related language. Multiple and repeat can have negative connotations, such as repeat offenders. Multiple and repeat also imply that each abortion experience for a woman is the same, whereas each abortion is surrounded by a unique set of circumstances. If safe, what is wrong with having multiple abortions? Because abortions happen under a wide range of cultural, legal, and medical circumstances, it is important to be careful about the terms that you use to avoid mixing up terms and creating confusion. Here are a few phrases to be aware of. Illegal abortions are those that do not comply with a country's legal framework but may be safe if performed by a trained provider or when a person has access to high quality medication, information, and support to safely undergo a medical abortion in a safe and licensed place. Remember, abortion is considered safe as per WHO guidelines when the three P's provider, place, and process are safe, trained, and certified. Unsafe abortions are performed by providers who are not registered or trained, or in situations where people are unable to safely undergo a medical abortion due to lack of access to high quality medication, information, or support. It is possible to have an unsafe legal abortion. Unwanted pregnancy is a pregnancy that a person decides they do not desire. Unplanned or unintended pregnancies refer to pregnancies that occur when a person is not trying to get pregnant. An unplanned or unintended pregnancy may be either a wanted or unwanted pregnancy. In India, abortion is legal, but sex selective abortion is illegal. Provider and place need to be safe, trained, and certified.
So after that short video, there are two self-paced games online. You can use these to see whether we have biases and what are the circumstances, how much we've understood the law. I've done that and they're quite nice. From 1970, we've had the MTP Act, but still we have unsafe abortions. In 2000, we had more number of safe abortions as healthcare providers did provide that. Now in the 2020s, we want not only safe abortions, we want respectful abortion. So in the chat box, you can answer. In WHO, according to WHO, when we restrict the access, will the number of unsafe abortions, will it reduce the number of unsafe abortions? So the statement is, according to WHO, restricting access reduces the number of unsafe abortions. So what do you think? Of course, it is false. So when access is not there, no one is going to continue a pregnancy if they do not want to have that, continue the pregnancy to term. So if we restrict the access, more number of unsafe abortions are going to be there. The MTP Amendment 2021 requires a minor to obtain written consent from parents, guardians before she can undergo a termination of pregnancy. So if you have been listening to, is that true or false? If you've been listening to Dr. Susila, you know that it is false. Basically, minor, the POXO reporting still needs to be done, but we need to be able to provide the service if there is a consenting adult. It does not need to be a parent or a guardian. And we need to provide bias-free services without judgment. A 30-year-old woman, recently widowed, wants to get an abortion at 22 weeks. As a provider, it is your responsibility to tell her to continue this pregnancy. Do you think if unfortunately we are in a situation like that, would we want to continue the pregnancy? I don't think so. But we need to remember it is 22 weeks. Her situation has changed recently. We need two registered medical practitioners to agree on that. In India, abortion is safe. So let us make it safe and respectful. And that is what this Samarth program is about. And thank you for your patient hearing and the various glitches I put you through.
Thank you, Dr. Padmaja. Any questions for this session? Please, you can post on the chat box. So next, I would request Dr. Navina to talk about pre and post abortion family planning services and counseling.
So
Dr.
here,
Navina?
Yes, ma'am.
There are some questions in this medical.
Yeah,
is Susila around?
Yeah, I'm here.
Susila, there was one question. Medical MTP kit, shall we have to admit, advise, take at home?
Yeah, according to WHO recommendations, it is like better we ask the patient to come on the day 3, and then after administration of the misoprostol, observe her for 4 to 5 hours, either in the emergency room or in the casualty somewhere. You can ask her to lie down and then you can observe. And later on, if most of the cases they do abort in like 4 to 6 hours, and then she can leave after that.
Yes. And there are others.
Like one more question was there regarding whether we can do MTP without anomalies. So basically we have to understand, we have to understand that there are only few changes that have been made from the 1971 Act. So rest of it is the same. So it was like 20 weeks is the upper limit, but it has been changed to 24 weeks in the vulnerable women. But otherwise it is 20 weeks. And anomalies at any gestational age, you can go ahead with abortion with medical board consensus. So if there is no anomaly, it doesn't mean that they can go for abortion up till 24 weeks. Only vulnerable group can go for abortion from 20 weeks to 24 weeks. Otherwise, it is only 20 weeks. Even the contraceptive failure part of it is only up till 20 weeks.
20 weeks.
So you should know who all are considered as a vulnerable group. That 7 points which have mentioned. So those people, those women are come under the vulnerable group. Otherwise, please don't do an abortion after 20 weeks. Again, you have to answer the law.
And abortion on a minor girl?
Abortion in a minor girl with a guardian signature, we can go ahead. It is not at all a problem. And this act has really it provides abortion to the minors, and they also come under the vulnerable group. Up to 24 weeks, we can go ahead with the abortion.
But we have to inform the police.
There is a question as, should we inform the police? Yes, we have to inform the police. Even if the girl is married, we need to inform the police.
Yes.
Yeah, that is a different subject which comes under the POXO Act. But this what dealing is the MTP Act. So MTP can be done up to 24 weeks in a minor or in a rape survivor.
And one more
signature, and then if she is more than 18 years, she can sign as well for her. If she is a minor, then we may need a guardian signature, that is who's like 18 years and above, maybe a friend, a maternal aunt, or somebody else, even a caretaker can sign for her, who takes the responsibility. It is not like only parent has to sign or somebody relative has to sign. So anybody can take the responsibility of managing the girl during the process. So this has been liberalized in this act to say it is not like really a relative. So we have the Form C, where the consent of the woman who's 18 has to sign in the upper part of it. If she's a minor, the guardian has to sign in the lower part of it. Nowhere like it is like a signature of husband is needed to say, not even in the tubectomy part. So I think the days are gone where you really need somebody, a guardian to sign, but nowhere I think we need husband signature in the present scenario of all this law. Even MTP and all these things, even cesareans, MTPs, any surgical procedures. Padmaja, is it am I right, Padmaja?
Tubectomy, it is a fertility issue where the male partner is involved. So as far as I remember, tubectomy, you need the husband's signature. Otherwise, for anything else, you don't.
Okay. I will just report with that.
Yeah. So I think if you're done, Uma, we can ask Navina to go ahead.
Ma'am, can you hear me?
Yes, Navina, go on.
Ma'am, this can you see my slides screen?
No. I think it is have to rejoin maybe in Navina. It is not.
Yes, ma'am. That's. Is it okay, ma'am? Now my screen is visible.
I think you need to.
Navina.
Your screen is visible, Navina, but a very small part.
Yeah.
Doing everything here, ma'am.
Navina, did you download it?
Yeah, I have downloaded, ma'am. I have bookmarked it as well.
Navina, shall I share? Will you talk?
Yes, ma'am. Thank you.
Stop share yours then.
Yes, ma'am. I'm stop share. Yes, ma'am. I've stopped sharing. Good evening for one and all, and thanks for the Foxy and Vox for giving me this opportunity to talk about pre and post abortion family planning counseling. And next slide, ma'am. I just my topic today is to focus more on the counseling and the family planning after post abortion. Counseling is a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts, feelings, and perceptions. Next, please, ma'am. So, coming to the pre and post abortion counseling, integral part of the comprehensive abortion services. It is an integral part, and it is as important as the procedure. And women may need help in the decision making, and whatever needed, the spouse should also be counseled. Next, please, ma'am. So pre-procedural counseling has a very critical role. It is to help the woman decide about termination of pregnancy and to choose the method of termination and to ensure the delivery of complete information about what procedure is to be done and to help a woman to adopt a contraceptive method post-abortion. Next. So, what do we do in a pre-procedural counseling? Ensure privacy and confidentiality, and be non-judgmental and be sensitive, as we have seen in the video. Use appropriate words. Establish the rapport with the patient. Use simple language and allow the woman to clarify her doubts. And if she has made up her mind for termination of a pregnancy, assess her for the procedure, whether we can carry the procedure or not. And relevance of peri-abortion family planning counseling. What can we do? Quick return to fertility. The woman should understand within 14 days of abortion, there is a quick return of fertility. So minimum of 6 months gap should be there before the next pregnancy. Opportune time for the contraceptive acceptance. She has to be given the methods of, she has to given what all the contraceptive methods, and she can choose it from that. And health benefits and better future pregnancy outcomes, we have to discuss all these during the abortion or before or after. 90% of the abortion related maternal mortality can be prevented by ensuring safe contraception. So pre-abortion family planning counseling, when we should start? At her first visit or consultation. And we can just delay it if there is any grief thing, when she's undergoing some grief. What to counsel? Importance, return to fertility, especially it can be between 10 days to 4 weeks, and help with the choices, method specific counseling, and high risk behavior wherever it is applicable. We need to talk to the woman. And the woman, if she is not willing for any contraceptive method, please do not refuse MTP. Try and counsel her after the procedure. If she's still not willing, call her for a follow-up in a week's time and then counsel again. Assessing the suitability for post-abortion contraception. If the abortion process is complete and if there is no existing infection and no injury to the genital organs and the chances of fresh pregnancy is ruled out, then we can assess the patient for post-abortion contraception. Post-procedure counseling, it has a critical role. Ensure the woman has understood the precautions and the care that should be taken during post-abortion period. Opportunity to counsel for contraception in case if not previously accepted. If the contraception is not accepted previously, we can go for post-procedure counseling. And reinforce the need for continuing the use of contraceptive method chosen. Post-procedure counseling, you should continue to ensure privacy. Same here, when we are providing the post-procedure counseling, there should be privacy and confidentiality. Reassure her in case of any problems and repeat the information about post-procedure care and danger signs. So post-abortion family counseling, if she has already opted for the post-abortion family planning, then appreciate her and immediately, like intrauterine contraceptive devices or depot progesterone MPA can be given immediately after the abortion, or oral pills, and tell her about the follow-up protocol and continuity of the medication, and we can give her the cards regarding the contraception. If she is undecided, allay her anxiety. Importance, tell her about the importance of the immediate adoption of adopting the method or to choose the method. Extended period of adoption. Like if she is undecided, let her come after 1 week or 10 days or 2 weeks to decide what she has to take or what she has chosen. A couple counseling and emergency contraceptive pills can also be discussed if she is undecided. Post abortion contraceptive methods. First, we discuss about the method, what timing they should be adopted, and additional information on the methods. Barrier methods like condoms, they are used as soon as the sexual activity is resumed in case of first trimester abortions, and in case of second trimester also as soon as the sexual activity is resumed. Main thing is they don't have any hormonal side effects. They can be used without consulting a healthcare provider. They're easily available anywhere. And additional is that prevention against the sexually transmitted infections and HIV, and enables men to take the responsibility of contraception. Other methods when coming to intrauterine contraceptive devices, we can go with the IUCD copper 380 or AG 380 or 375 multi-load. They can be during first trimester, it can be inserted immediately or up to 12 days after confirmation of a complete abortion, in case of in using the surgical method with medical management of abortion. Inserted around day 15 of the process, provided after checking with a check scan there is no products of conception, then you can insert a IUCD. And after the second trimester abortion, it can be inserted immediately or up to 12 days after the procedure is complete, and no contraindications are ruled out after second trimester. These are highly effective and they provide a long-term contraceptive for 5 years or 10 years, and it can be provided by medical trained doctors, ANMs, nurses after first trimester surgical abortions by trained doctors only. After MMA and by PPIUCD trained doctors after second trimester abortions. No interference with the sexual activity, immediate return to fertility on removal, and no hormonal side effects. These are the advantages of IUCDs. Next method, hormonal contraception. As we all know, combined oral contraceptive pills. After the first trimester abortion, we can immediately or up to 7 days after the abortion using surgical method. If medical method is opted, it can be started on day 3 with the dose of misoprostol or within day 15 of the process after confirmation of the completed abortion. In case of second trimester, immediately or up to 7 days after abortion. They regulate menstrual cycles. They can be provided by all health workers after first screening by the trained provider. They don't interfere with the sexual activity of the couple. They offer protection against ectopic pregnancy, endometrial and ovarian carcinomas, and benign diseases such as fibrocystic and fibroadenomatosis of the breast. Not suitable for women who are breastfeeding babies less than 6 months old because they prevent lactation. Next, hormonal contraception. They are long-term injectables, medroxyprogesterone acetate. First trimester abortions, immediately or up to 7 days after abortion when we are using surgical method. With medical methods, it can be started on day 3 with a dose of misoprostol. Second trimester abortions, immediately or up to 7 days of abortion, we can give the patient the option. These are highly effective. Confidentiality and privacy is maintained, can be provided by doctors, MBBS or Ayush, ANMs, nurses after screening by the doctors for the first injection. No interference with the sexual activity. No effect on the quality and quantity of breast milk. No estrogenic side effects. Offers protection against ectopic pregnancy, ovarian cancer, iron deficiency, anemia, and uterine fibroids as well. Next slide. So coming to the permanent methods, there are female sterilization and vasectomy. Female sterilization after the first trimester abortions, it can be performed after an abortion in the absence of any infection or severe blood loss, concurrently up to 7 days. Both by mini lap or laparoscopic sterilization can be done. With medical management of abortion, it can be done only after the first menstrual cycle after the abortion. Following second trimester abortions, mini lap sterilization can be performed concurrently or up to 7 days after an abortion in the absence of infection or in the absence of any infection or severe blood loss. Usually here laparoscopic sterilization is not recommended. This is like advantages is like permanent method of contraception. It's highly effective and is effective immediately. No interference with the sexual activity, no effect on breastfeeding, no long-term side effects, offers protection against ovarian cancer. Coming to the vasectomy, it is performed on males independent of the timing and procedure of the abortion. It's very effective and permanent method of contraception. No interference of with sex, no long-term health risk. But couple must use another 3 months of other contraceptive methods if they are opting for vasectomy till the sperm sample become azoospermic. This is just a slide given when we have to use, when can be injectables used after from 3 days to day 15, when we cannot use the injections and all. Here the additional point given was centroman. Nowadays we are not using centroman. Contraceptive methods with vacuum aspiration, COCs can be given from day 1 to 7. Injections can be given from day 1 to 7. Centroman can be given. IUCD can be given from day 1 to day 12, and tubal ligation can be done at any time after the abortion at any time. So SRH services, these are the services, teleconsultations and other technologies where we can use. What is the leverage of these service provisions is like teleconsultation, telecounseling, teleguidance, telereference and telelinkage. Next, ma'am. So here we leverage technology like there is a website called Hamdod where the patient can go and read about this. And social media is like there is a program on radio regarding Ask Tanu, and there are YouTube videos made making people aware of the things, and infographics. Helpline numbers are there for the patients to seek counseling or to seek the abortive methods, or where they can go for an abortion. And patient education platforms, that's like a WHO, RCOG, they have all given a big topics were given where the patient can go and search for the what are the abortion cares can be taken and all. This is the strength. What is teleconsultation strengths, weaknesses, opportunities and threat? The strength is in this COVID era when we cannot see the patients directly, it is approachable throughout the process, and confidentiality is maintained, awareness can be increased. And weakness is like the demonstration face to face, patient may not obtain all the information, or there might be some disturbances and all. Regarding the opportunity, it is like teleconsultation offers privacy and comfort. It is a cost saving, and number of visits to the doctor is cut down. Sometimes misdiagnosis can be made because we are not clinically seeing the patients, and the opportunity is also missed sometimes. So that is the threat for the applicability of the comprehensive abortion care is like assessment, counseling and follow-up. First, confirm the diagnosis. Contraceptive need should be made. Counseling can be made via video conference or Zoom. Follow-up, we can use teleconsultation for the counseling. Then she can come to the hospital using hybrid services, 1 visit. In case of medical management of abortions, 3 visits. We can actually we can tailor made, we can use or we can adapt anything which is more suitable for us and our patients. The key message is realize the need for the post-abortal family planning, bring the couple on board and strive for 100% coverage, capitalize on the basket and applicability in the post-abortal period, technology as far as possible use for the scope for entry in CSC services, their concerns, policies, everything can be discussed. Adolescent RH needs both online and offline. Sorry. Once again, reminding all of you to do a post test and give a feedback so that you all can get a training certificate on respective abortion care. That's it, ma'am. So let us make it together. Safe abortion for everyone who is
Thank you.
opting.
There's one question, Susila, Anti-D on to give mifepristone or misoprostol. I think you covered that, Susila.
Day 1 with mifepristone.
At the day of mifepristone, because sometimes people abort with mifepristone.
75% of
mifepristone.
It is complete with mifepristone and 75% of them.
Yeah.
Yes, ma'am.
It is always better to give on the day 1 rather than on day 3. But still day 3 also covers the 72 hours halo, but still we can give, better is to give on the day 1.
I think the one of the reasons is because sometimes very early with mifepristone itself, they'll abort and they will not turn up.
Yeah. No,
but on the same day, at least we are sure about that. Although we tell them to come back, sometimes they give a call telling I'm okay, I will not be coming back. Like
we may miss them because they think that the completion is like with mifepristone, but we should also make it a point like we have to insert the misoprostol to complete total process.
Yes.
So even though they abort, we are bound to do that.
Yeah. And for once you leave the meeting, you will get, do you want to
a pop-up
pop-up will come that you can finish the post test right now, so that otherwise again through a mail and all is very difficult. So you, after you leave the meeting, click on the pop-up, don't exit Zoom, finish your post test, give the feedback and then come exit. Okay. That's the message Dr. Selja wanted me to give. And Dr. Uma, do you have anything else to say?
Ma'am,
no.
If an unmarried girl of like 18 to 20 years of that age group, if they want to opt for medroxyprogesterone, depoprogesterone, can we give them that?
Yes.
Yeah, we can.
We can.
Okay.
So you are worried regarding the epiphyseal closure, right, Navina?
No. 18 years epiphyseal will always happen.
Some girls will have.
No, the thing is within 5 years of menarche, the epiphyseal occurs. So if they've had it 13 by 18, that will happen.
Oh.
Parnaja, madam, sorry to interrupt.
Yes.
Madam, I shared the post test link in the chat box only.
Okay.
Just copy the link, they can do it, madam.
Okay, fine. So all the 60 participants other than the 4 of us, please copy down that link from the chat box and you can answer and get off your certificates.
Please check for the certificates in spam folders and promotions.
Yes.
One more thing I would like to just tell all the doctors, that is the previous act is in place. So we should know the previous act also. For whom all we should do whom all they are eligible to undergo the abortion. So there are 5 to 6 changes that have been made. So we need to know about the previous abortion law, and also we have to know about the newer amendments in this law. So it is incomplete only to just go through about these 5 or 6 changes that have been made. So to whom all women we can have the access of abortion care and all, we need to really read from the 1971 Amendment Act.
Yeah, this is in additional to the 1971.
Only
So the
few
modifications, with the modifications, that's all.
Yes, that's all.
our friends have posted whether we can do without any anomaly. So we like normally regularly also, if it is a contraceptive failure or it is going to cause any grievous injury to the woman's health, either physically or mentally, or she has taken some drugs and fetus is going to like really have anomalies, then we do go for MTPs in such women. So this holds good even up till the 20 weeks. So what addition is done is from 20 to 24, those 7 group of people who are considered as a vulnerable group. And the fetal anomalies, there is no upper limit if it is really lethal and then baby is going to have serious mental physical abnormalities and it is going to cause handicap problems and all. So that is the like really what we need to know is regarding this.
So, ma'am, every month ending that Form 3 needs to be sent to DMHO office?
We need to send it. We need to send it and we have to maintain the confidentiality. It was like previously, like anybody who comes from the government, we can like really open and show. It is not so now. They have the
Yes,
proper
ma'am.
letter with them and then and the other big problem is that we cannot like either in OP file or IP file, we cannot mention their name or the details. We have to write the admission number, what we give.
Okay.
So, yeah, so we have to modify in our like computer systems to say. So nowadays, most of the hospitals, we have the registration counter with computers. So
Yes, ma'am.
it is like we have to like edit and then give the number.
Oh, okay.
So we have to have the edit option at the registration counter.
So if there are no more questions,
Shall we call it a day then?
Uma has to give us permission to leave.
Yeah, I think most of the questions are answered. Yeah.
So there is one more question, like we don't need husband's signature. Yes, we don't need husband's
We
signature.
don't need husband's signature.
We didn't need husband signature, yeah. There was one question specifically asking about, should we inform police? So that comes under POSCO Act to inform police. MTP, you can go ahead as a routine, whatever are by the recommendations, but yes, you need to inform police and you can do MTP. Yeah, any other questions? Otherwise, just do the post test. Otherwise, you wouldn't be given a certificate.
Yeah.
Yeah,
So
that's it. I think we can close this.
Thank you, Shriman, for the support you've given us. And thanks everyone for putting up with all our glitches. And we know MTP is a dry area, but Susila has extensively covered all the do's and don'ts and the buts and ifs. And Avina has talked about the contraception. And as I said, we need to change our language and the way we talk. So,
Yeah.
okay, thank you.
Yes, ma'am.
హలో హలో పద్మజ. ఏంటి according to the World Health Organization, legally restricting abortion.
Madam, please copy that link and you can leave the meeting.
The law was amended recently, expanding access to abortion services on therapeutic, eugenic, and social grounds. In my country, only registered medical practitioners are obligated to